Hello there. I'm Ken Mayer from Boston. I'm going to be talking about PrEP. Where are we now? So the good news is that PrEP works if people are adherent. These are data from the clinical trials. And we have real world data from demonstration projects that show a high level of efficacy and a low level of toxicity. So where are we globally and why do we need new modalities? Well, by the end of 2020, there were more than 70 country programs with 1 million people on PrEP worldwide, which is the good news. But unfortunately, the goal of the WHO program was to have 3 million people on PrEP by 2020. So we still have a shortfall. There are countries that have been leaders in this. You can see that USA, South Africa, Kenya have very high levels. And in Latin America, Brazil is the leader in terms of the number of people on PrEP. And there are data that say that countries that have adopted PrEP in conjunction with undetectable equals untransmittable, rates of new HIV infections have fallen, but there still were 1.7 million new HIV infections in 2020. So I want to talk a little bit about where we are and where the future may be. One of the biggest challenges about PrEP is the fact that there's a substantial drop off in the patterns of persistence over time. So one of the big challenges is once people start PrEP is to keep them on PrEP or to help them appreciate their risk. One exciting example that has emerged in the past few years has been the idea of same-day PrEP to really take advantage of opportunities. So these are data from New York City's sexual health clinics. They identified almost 1,500 people who came in for STI screening, and by their profile, they would have met indications for PrEP. They were engaging in frequent condomless, either penile anal, penile vaginal sex. They ruled out people who had a history of kidney disease, hepatitis B infection, acute HIV, and they found that the vast majority screened out. And of those individuals, they then started them on PrEP the same day, and they found only 4 of those individuals they had to subsequently stop PrEP, where 2 people were acutely HIV infected and 2 people had lower GFRs. So 99% of people were able to start same-day PrEP. Of the people who they deferred to start PrEP, they found that a substantial number of those individuals were still PrEP eligible once they had the testing done, but those individuals had a much lower rate of starting PrEP. So this idea of same-day PrEP is another new innovation to try to take advantage of situations where people may be aware of their sexual health risk and therefore be more amenable to PrEP. The other approaches are new products. So I call the first generation of beyond tenofovir and emtricitabine as PrEP 2.0. One version of this is TAF, tenofovir alafenamide. I show you data over on this slide of the Discover study, which basically found comparable very low rates of HIV infection with FTAF and less changes in bone and renal endpoints from baseline compared to tenofovir disoproxil fumarate, TDF, FTC. But these were not necessarily clinically significant. They were findings that were seen in terms of the biology. Similarly, there was a modest weight gain and a less favorable lipid profile with TAF, but again, not associated with clinical findings. And cost may be a consideration with TAF, but it is another modality. There are other modalities as well, which include OnDemand Prep and the dapivirine ring. OnDemand Prep, these are data from the follow-on study from the IPERGAY study led by Jean-Michel Molina. This followed men of sex with men in France and in Quebec. This follow-on study, individuals were offered open label to either get daily PrEP or on-demand PrEP. That would be 2 pills within 24 hours of sex and a pill a day for 2 days after sex. And what they basically found was a very low rate of HIV infection in both arms. Only 2 incident HIV infections in both groups, so that the incidence was 0.12% in both settings. They estimated that they avoided more than 350 HIV infections. And the background incidence in that community was over 6%. So a radical reduction. What was most interesting about the study was they also allowed individuals to switch back and forth between on-demand and daily PrEP. And you can see here about half elected at any given time to take daily PrEP and about half elected to take on-demand PrEP. But what is very interesting is the fact that about 20%, almost a quarter of the cohort, switched from one to the other. And so offering this as a menu, I think, is another way to increase PrEP uptake. The dapivirine ring is very exciting. There were studies in sub-Saharan Africa, 2 parallel studies, that showed that it did decrease HIV incidence, but it was modest, and there were concerns about adherence in the real world. But there have been subsequent studies now, and they found that the majority of women who elect to start the ring will continue to use the ring at every visit. The returned rings had pharmacologic data supporting use, and the dapivirine definitely worked. The European Medicine Association has approved this daily ring. It's recommended by the WHO, and in many parts of the world, this is another option for women to protect themselves against HIV. And another reason it's very exciting is it may offer multi-purpose technology. So there are rings that can be given every 3 months that are being developed, and also multi-purpose rings that contain hormonal contraception. So this is the first generation of the rings, but another approach for HIV prevention. There are a whole variety of other new approaches coming down the pike, which address different challenges with PrEP 1.0. So you can see here that there are many in preclinical trials. There are not so many in phase 3 studies, and I want to tell you about a couple of them. One is injectable cabotegravir. There have been now 2 randomized controlled studies, HB10083 in men who have sex with men and transgender people, and HB10084 in cisgender women in sub-Saharan Africa, and both showed actual superiority of injections of cabotegravir every 8 weeks. Cabotegravir is an integrase strand transfer inhibitor formulated in a way that it can be given infrequently. So injectable PrEP is a reality now. It has not yet been approved by regulatory authorities, but those applications are underway. So we can anticipate by 2022, certainly this being available in many settings. Another interesting approach is less frequent oral medication. Islatravir is being developed for this indication. It is a translocation inhibitor, so it has a somewhat unique mechanism of action. The pharmacology is quite favorable, and it now is being developed as a pill that can be given once a month. It also is being developed for use to be an implantable rod, and that is because the company that's developing it, Merck, also makes a hormonal implantable rod. This rod can be implanted subcutaneously and will release medication over the course of a year. So this may be another way to offer dual purpose technology for women, which can prevent conception as well as prevent HIV. The islatravir oral program right now for the monthly pill is underway. There are 2 studies enrolling cisgender women and cisgender men and transgender women. They're parallel studies and very exciting going forward. So we may have a pill that can be given once a month. The other very interesting medication is lenacapavir. This is a capsid inhibitor, so a unique mechanism of action, very long half-life, and there are 2 studies now getting underway, one in young women and one in men who have sex with men and transgender people. And what's interesting about these studies, the study design, is that it's comparing injections every 6 months with daily oral tenofovir-based PrEP, and both arms are active, but they're being compared to a cross-sectional incidence cohort. So this is taking individuals who screen in for the study and trying to determine when they became infected with HIV and back calculating what is thought to be the background incidence of HIV in the local community. So this is the study design for the trial in adolescent girls and young women. And here's the similar study design for men who have sex with men and transgender and non-binary individuals. And these studies are also studies in men who have sex with men and transgender people enrolling in Latin America. There are other approaches that are in the future that are underway. One idea is another kind of PrEP implant using tenofovir alafenamide, but there was a study in monkeys and they found actually local skin reactions and found necrosis. So they're going to have to redevelop this. There's also a cabotegravir implant that is being studied as well. So this idea of implants and long-acting PrEP is quite is quite in the vogue, and we'll see how that develops. So there are pros and cons about these different approaches. One can think that they may improve adherence. There's less frequent monitoring, less frequent healthcare visits and discretion, but we still need to learn more about the PK, about clinic visits, service distribution models, and how this is integrated with reproductive health issues for women. And with the injectables, very similar kinds of issues. And with the injectables, because of the very long half-life, we have to understand the tail. What happens if somebody stops the medication, doesn't start oral medication, and continues to be risky? Will they select for resistance? So we need more information in this regard as well. It's important to understand the consumer voice. So these are data from a study that our colleagues did that was using sexual networking sites from around the United States. And interestingly, we found that there was the greatest interest in injectable PrEP, more so than other approaches. And what came out were that people had different reasons for being interested or not interested in different approaches. And there were different concerns. So the people who didn't like injectable PrEP were concerned about the long-acting side effects. The idea of infusible antibodies, they didn't like the idea of IV infusions. And for pericoital gel, people thought it would be messy, or the douche might be messy as well. So we have to understand the consumer voice. One other approach that we have to keep in mind is the issue of immunoprophylaxis, using antibodies to protect against HIV. The AMP trials were two large studies, one conducted in men who have sex with men and transgender women in North and South America, and one conducted in cisgender at-risk women in sub-Saharan Africa. And what the studies basically found was that overall, the infusion of one monoclonal antibody was not protective against HIV overall. But when they went back and looked at the concentrations, the concentration needed to prevent the virus from replicating, they found that some of the strains tended to be more susceptible, and more susceptible strains in the real world were inhibited by the single monoclonal antibody. So it's sort of a proof of concept. It's very similar to AZT in the early days of the HIV epidemic, where it had some activity, but not enough to be effective. So the thought is to use combinations of monoclonal antibodies, and there are now studies underway looking for the right combinations. You can see here, there are a huge number of monoclonal antibodies. So in the future, we might be able to protect people against HIV by using a monoclonal antibody cocktail, but this is further down the road than some of the other approaches I've mentioned. We also have to be aware with PrEP that it is associated with increased bacterial infections. And this was a study from Australia that looked very carefully and showed that part of the increase was more frequent screening that we do for people on PrEP, but part of it was an actual increase in condomless sex. But that's the reason why people would use PrEP. So increased STDs, not a reason not to offer PrEP. And in point of fact, we looked at our own data at Fenway Health, and you can see here in the purple line, the rate of STIs went up quite a large amount, eightfold over the course of a decade. But a large number of the people who presented with bacterial sexually transmitted infections were people who were living with HIV, so they're not PrEP candidates, or people who were HIV uninfected, but not on PrEP, you could argue needed PrEP. So you can see by 2015, there was a large chunk of the people with STIs in red were PrEP users, but if you add the blue and the green bars together, that's still a larger number of people. So we have to be aware that we're in a new era, that there's social media, there's sexual networking sites that are associated with increased sexual risk. In the United States and other parts of the world, the expansion of the Affordable Care Act or increased access to healthcare means more people are getting screened, and there's increased comfort on clinicians of extragenital screening. So it's not just one narrative, but certainly PrEP is part of this, but I think we have to use the fact that there are increased STIs as an opportunity to screen people and treat the STIs and not to avoid giving people PrEP. One of the last challenges I want to mention is the idea of who prescribes PrEP. And there's a little bit of this people pointing in opposite directions. So for HIV providers, they oftentimes will say primary care providers are in the best position to provide PrEP. And primary care providers would say it may not be feasible. I don't know about these antiretroviral medications. And what we really need to do is get people to talk to each other, to know the local epidemiology, because in some communities, it may make sense for primary care providers to be the major PrEP providers. Other places may benefit from specialized clinics. We did a study in our own clinic in Boston, which takes care of a lot of sexual and gender minority people. We have high rates of PrEP uptake, but we compared the people who were using PrEP with the people who weren't using PrEP, who were similar demographic profile. And we found that people who were using PrEP were more likely to get a flu vaccination against influenza. They're more likely to be screened for tobacco and screened for depression and screened for diabetes. So our argument is that PrEP may be a gateway to care. So, for clinics that are providing more generalized care, PrEP is an opportunity to engage people in other preventive health services. So in conclusion, the uptake of PrEP and biobehavioral prevention modalities, it's been suboptimal. We don't have enough people on PrEP, 1 million of 3 million projected in 2020. Development of new approaches is going to offer opportunities for less frequent dosing, culturally congruent modes of delivery, so that's going to be important, and the possibility of MPTs, which are multi-purpose technologies. So for women in particular, hormonal contraception and HIV prevention may be able to be offered in a single pill or a single implant. Future prevention may also include antibody cocktails and ultimately vaccines, but for the time being, our focus are going to be on antiretroviral medications. Insufficient adherence and decreased rates of uptake are not exclusively due to dislike of pill taking. So we have to think of ways to really engage people to be more adherent to medication. And ultimately, for PrEP to achieve its promise, we also have to address social, structural, individual behavioral issues. And these issues have to also be thought about because the pill will not take itself. So we have to create an environment where people are willing to engage, either to take the pill or come in for their shots. So I just want to thank some colleagues who provided ideas and information for this talk. And I want to thank you for your attention. Obrigado.